everyone, and welcome to our lecture on mental health and aging. This is a very important topic and very pertinent to the older population. We are not going to be able to take a very deep dive in 17 slides, but I'm hoping to give you an overview and some resources that you can use in your future. So the statistics show us that 1 in 5 people over 55 years old has some sort of mental health condition. I would imagine that all of you know at least 5 people over 55, so at least one of them has a mental health concern. My experience, and of course that's the majority of my experience with older people has been in the skilled nursing facility setting, which has a higher incidence, but my experience is that way more than 1 in 5 have a diagnosis specifically of depression and anxiety, and they seem to go together, and we'll talk about that. Uh, One thing that I found surprising when I was researching this is that the highest suicide rate in the nation is for men 85 and older. I was just thinking that it was probably teenagers. Um, so very interesting. We'll talk about that also. Um, One thing I want you to remember when you're thinking about these mental health conditions is that mental health conditions, cognitive impairments, things like that are not a normal part of aging, even though they are common. So let's talk about depression or a major depressive episode. I am not going to bore you and insult you by reading you the DSM-5 criterion, but there are 5, you have to pick at least 5 from the list, and they have to be pervasive for at least 2 weeks. You can read them there in front of you. That's how this is diagnosed. Um, One thing you might be thinking is, well, I would think that somebody who has a history of depression as a younger adult is more likely to have depression as an older adult, and that is true. That does carry with a person. However, 50% of people who are older adults experience their first episode of depression once they become an older adult. So just because you have no diagnosis of depression as a younger person doesn't mean that you will not experience it as an older person. Um, One thing about these conditions, not just depression, but mental health conditions in general, are they are greatly underreported in older people. My guess, and that's what this is, but based on my experience, is that that's very multifactorial. A lot of older people are afraid of being removed from their homes or being deemed incompetent, so they don't report problems that they're having. A lot of family members don't recognize things in order to report them, or I think sometimes people think that depression and cognitive impairments, certain mental health conditions are just a normal part of aging. So, oh, grandma's senile and just let's let it go. Um, the highest risk of depression is in long-term care settings. And why do you think that is? I was going to have a discussion on this if we had the lecture in class, but let me discuss it with you from my perspective. I think it's, again, very multifactorial. I think that the reason that we see more depression in long-term care is, number one, they're in long-term care. They're not home. And almost universally, people say, I just want to go home. I don't like being in a facility. That's number one. But then let's consider why they are in a long-term care setting. They're in long-term care settings most likely because they have a very severe chronic and or progressive condition. So these are very sick people. These are not people who are able to be cared for at home or are able to care for themselves at home. So they have a lot of medical issues on top of that, which then spins off into emotional issues and potentially depression. So who is especially at risk for depression? Um, what I did was I took this directly out of your textbook. So you have access to this in other places too. And your question might be, oh gosh, am I going to have to list a bunch of these or am I going to have to memorize these? No, you're not. But what I want you to do is let's talk about the trend of who is at risk for depression, because I certainly want you to keep that in mind. That's going to be important when you're working with your older clients, to kind of just keep your antennas up. That they tend to have this trending in their life, that they're more at risk for depression. So if you look at the social factors: unmarried, living alone, lack of social support, negative events, i.e. the death of a loved one, obviously then that should clue you that somebody's at risk for depression. That should not be surprising. Uh, we already talked about caregiving and how stressful that can be. So obviously that can contribute. Uh, for all of these mental conditions, if somebody has a pre-existing condition as a young adult, obviously they are more likely to develop it as an older adult. And then the medical factors, we talked about that in relation to depression in skilled nursing facilities. The more chronic conditions you have, the sicker you are, the more likely you are to be depressed. So in general, um, loneliness and lack of social support, uh, stressors in life such as loss of a spouse or caregiver stress, and um, medical conditions. That's what puts people at risk for depression. Again, if this had been an in-class lecture, this would have been a discussion. So I'm going to discuss it with you. So what do you think the occupational performance deficits are that would be associated with depression? Well, what does depression look like? Depression presents differently with different people. However, in general, people with depression have decreased interest in participation in any type of activity. So they tend to be more disheveled. They don't have the energy to get up and get dressed and get showered. So maybe they don't do that. They don't see the purpose in it. Why get up when I have nothing to do and nowhere to go? And why should I shower under those circumstances? Uh, you can offer them something interesting to do that might have interested them in the past, but they don't care anymore. So there's decreased desire to participate in leisure activities that used to interest them. Uh, there's a lot of feeling of worthlessness. It's very, very common to hear, especially in long-term care facilities. I have no purpose in life. I'm a burden. I wish I would just die. Uh, Obviously, those are signs of depression, and it interferes with every aspect of self-care. Very frequently, there is a loss of appetite, loss of interest in food. Uh, so every single area of life is impacted by depression. So suicide is not a diagnosis. It is something that falls on the far extreme end of depression, usually. There are other reasons why people might commit suicide other than depression, but in the older population, it is most frequently associated with depression. Uh, One thing that I found very, very interesting is that older people generally complete suicides at a higher rate than younger people. Younger people uh, who attempt suicide, the likelihood that they complete the suicide is less than for the older people. Why is that? Well, older people generally use guns. 70% or firearms, I guess, guns, rifles, whatever. Older people generally use a more lethal form of suicide, and therefore have a higher level of completing, and they're more likely to live alone than younger people. So potentially a younger person might unfortunately try to shoot themselves, but they might be found and taken to the hospital, whereas an older person might be there for a couple days and obviously will have passed in the interim. Also, older people are more frail. They have more pre-existing conditions. They have cardiovascular disease. They have cognitive impairments. They have neuromuscular diseases. They have things that make them more frail. They have pulmonary issues, so they are more likely to succumb to a suicide attempt than a younger person. One thing I want to mention on the last slide, it said taking the stigma out of mental health. And that's one thing. Older people tend to be very private, very proud, or maybe not even recognize their own symptoms of depression. So your ability as an occupational therapist to connect with these people and to speak with them and help them to open up could actually be life-saving. So really, I said keep your antennas up, but really do keep your antennas up because you might be the one who really discovers what's going on with this person and be their lifeline. Bipolar disorder. As I was researching this, I found it very interesting to realize that bipolar disorder, which used to be called manic depression, hence bipolar, two sides. You've got the mania, and then you've got the other side, which is depression. According to the DSM-5, to be considered a bipolar disorder, a person only has to be manic. They can also have periods of depression, but they can be diagnosed with bipolar with only symptoms of mania. Again, I'm not going to insult you by reading the whole thing. You can look over those, and I believe you probably know what mania exists, what mania is. And the acronym for the symptoms of mania are DIGFAST. I think that's interesting. It kind of helps you to remember some of them. Obviously, you will have the opportunity to, in your practice, go back and check if you ever need that. I'm not going to ask you to memorize it, but if it's something that, if you find yourself in a job where you see a lot of mental health disorders, and actually if you work with older people, you are going to see a lot of mental health disorders. It's something that you just might want to keep in the back of your mind. So again, I have provided you with the table from your textbook on the risk factors for bipolar. The thing I want you to remember about bipolar disorder, for mania in particular, is that this is generally a primary diagnosis. It is a neurotransmitter, neurochemical kind of thing, as opposed to depression tends to be more situational. A person will become depressed in response to loneliness, loss of a loved one, caregiver stress, whereas bipolar tends to be more of a neurochemical condition. When it is secondary to when it is a secondary diagnosis, it's usually due to substance abuse. So that's something that I would like you to remember. So what might you expect that occupational performance deficits are, specifically with mania? Uh, as you know, when a person is manic, they're very, very grandiose. They lack insight into their limitations, whether they be physical limitations, cognitive limitations, financial limitations. They tend to spend lots of money on huge projects or overestimate their ability. I have a picture of this guy going up on the roof and falling off because he decided that he was going to potentially reshingle his entire roof by himself in his state of mania. So especially when we have older people who have limited physical abilities, potentially limited cognitive abilities, which are very common as people age, unfortunately. Very frequently, these people are on fixed incomes. So if they go on a buying spree and decide they want to buy every grandchild that they have a brand new car, or they binge watch Home Shopping Network and they buy 7 or 8 of everything that comes up, those things really happen. So the person tends to sleep very poorly. So every aspect again of life is involved when somebody is going through a manic episode, uh, but certainly in a different way that it's impacted when they are depressed. Let's talk about anxiety now. We all have anxiety. To live is to have anxiety and stressors. That is normal. It becomes a problem when the level of anxiety increases so much that it interferes with our ability to function. Uh, so 6 to 10% of all elderly people experience anxiety. I am telling you anecdotally that it's way, way higher for people who are in long-term care facilities, skilled nursing, even probably in assisted living facilities and maybe even independent living facilities. These are people who have experienced something that has made it so that they cannot live in the community as they would prefer. So that puts them at higher risk for anxiety. And there are different kinds of anxiety disorders. 3% of people have a generalized anxiety disorder. They just have excessive worry about whatever it is. It is super, super common in this population to see a diagnosis of anxiety and depression. They go hand in hand like peanut butter and jelly or whatever else goes hand in hand. I see it all the time when I'm working with this population. Uh, the increased risk is cardiovascular disease, GI diseases, and arthritis. The first two make sense to me. Cardiovascular disease, because if you're stressed all the time, that puts you at higher risk for cardiovascular disease. And there's also a lot of research that shows that people who have had cardiac events or have cardiac conditions demonstrate a significantly higher rate of anxiety than people in the regular population. GI diseases make sense to me because when you're stressed and nervous, it can be upsetting to your stomach. I wasn't sure about arthritis and I tried looking it up and I don't see why. However, that's what the information in the research shows. So arthritis also puts you at higher risk for anxiety disorder, maybe pain and decreased function. Not sure. So panic disorder is another type of an anxiety disorder. It's rare to be diagnosed first in older people. Of course, if somebody has a panic disorder as a younger person and they are 54 and they have it, when they turn 55, they still have it. So people who have pre-existing mental health conditions, take them with them. So what happens when someone has a panic attack? I will tell you about I do not have a panic disorder, thank goodness, but I have had one panic attack in my life. It was my very, very first job. I was assigned to the neuro floor of an acute hospital, and it was a teaching hospital. And the neurologist would always make rounds. The therapist had to go with him, as well as his medical students and his residents and the fellows, and he would bark out questions. You, what do you think of this? You, what do you think of that? And unfortunately, the therapists were in the firing line too. And I was a brand new therapist. I didn't really have experience with anything, much less tricky questions about neurology. Um, he terrified me. And I remember I stood in the back. I tried to hide behind everybody, and I was leaning against the wall. And all of a sudden, my vision collapsed. It just kind of started in the periphery, and it got smaller and smaller and smaller. And I was fully conscious, but I could not see. And then all of a sudden, my hearing started to get crackly, kind of like a radio that wasn't quite tuned in to the station properly. And then the next thing that I knew, I was lying on the mat in the OT clinic. How embarrassing. But I had become sweaty, so somewhat diaphoretic, and just passed out. Um, so anyway, it's really scary. It certainly did impair my ability to function, but that was my experience with the panic disorder. I cannot imagine living with this kind of condition where it happens frequently um, throughout my life. Well, we've all heard of PTSD, post-traumatic stress disorder. This is another anxiety condition. Uh, my experience with this older population is that a lot of men, I've had a lot of patients who were World War II veterans, veterans from the Korean War, Vietnam War, and they have seen and experienced horrendous things. These folks don't like to talk about it. They tend to just stuff it down and move on, but you never know what is going to trigger these folks. Um, I don't know if they hear a car backfire or somebody starts yelling or they hear sirens. You just never know. Post-traumatic stress disorder can also result um, from coming out of an abusive relationship or having had an abusive relationship. There are so many things that can cause post-traumatic stress. Uh, it is definitely underreported. These people tend to try to tough it out. Um, I I wonder if it's because back in, oh, I don't know, World War II in Korea especially, this wasn't even a thing. PTSD wasn't described, it wasn't diagnosed. And these people were expected to just come home and resume normal lives after living through horrific situations that no human should ever have to endure. So um, they just kept a stiff upper lip, and a lot of them developed alcoholism and other ways of dealing with this. I know there's somebody in my family, an older person who served in Vietnam, and he turned to alcohol and pills. And happy to report he just celebrated 5 years of sobriety, but a lot of people don't make it to that point. So post-traumatic stress disorder, a real thing. It's important to talk about with people about their past, see if they'll share, so that you know if this might be an issue in their life. OCD, we all laugh, oh, she's OCD, he's OCD, but people who truly are OCD can really be trapped by this. Obsessions are recurring thoughts that they can't get rid of, and compulsions are actions they have to take to relieve their anxiety or to avoid some imagined negative consequence. So these are the people who have rituals where they go through the house and they have to unlock and lock certain doors 3 times, and check the stove and flip lights on and off and wash their hands in a certain way for a certain amount of time at a certain time of day. It is not common in older people, less than 1%, but it's worth talking about when we're talking about anxiety. And then, of course, there are phobias. The most common is agoraphobia, which is the fear of leaving home. This is relatively common. You don't see it a lot because they're hiding at home, but they're frequently associated with fear of falling, which that stands to reason, right? They're afraid of going out, going up and down steps, on sidewalks, across parking lots, uneven surfaces of a lawn. So if you stay inside, then you decrease your risk of falling, supposedly. So that's relatively common in the older population. How do you think anxiety interferes with occupational performance? Well, let's think about a time when you were exceptionally anxious. When you are really anxious and uptight and nervous or scared, are you able to think clearly? Can you sit down and focus? Can you prioritize things that need to be done in your life? Uh, and then now the answer obviously is no. You can't do any of those things well. And now let's go ahead and lay depression over the top of the anxiety. So now you're anxious, you can't think, you can't prioritize, you can't sequence, And now you're depressed on top of that. You have no energy. You have no desire. Uh, you don't see a purpose to eating or even reaching out to ask for help because you're not worth it anyway. So, once again, anxiety, especially combined with depression, but can be by itself, causes extreme limitations and deficits in all areas of ADL and IADL. So, psychosis also exists within the elderly. Uh, if you remember from any of your psych courses, psychosis is a break with reality, and they are frequently associated with hallucinations, which can be auditory, visual, tactile, or auditory, or delusions. Delusions are false beliefs. Someone believes that um, they are the Messiah, or that Satan has come and told them to do whatever it is that Satan might tell them to do. Uh, Delusions can also be somewhat more realistic. My son is stealing from me. That's very common with someone with cognitive and memory deficits because they can't find things, so then they have delusions that people are stealing from them. So let's talk about schizophrenia. It is very rare to have what's considered to be a very late onset schizophrenia, which is after age 60. Most schizophrenia is diagnosed in young adulthood, so only 4% of diagnosed cases occur after age 60, and they usually have less severe symptoms, which that's nice. Um, the prevalence of schizophrenia in the general population is 1%, but it's only about 0.5% in older adults. So that just shows that the prevalence does decrease. It makes me wonder if it's because people with schizophrenia, if you're diagnosed with schizophrenia at age 20, is your expected lifespan shorter? That's just something that I wonder about. Something to look into, but maybe that's why too. Anyway, one thing that you will see, there are quite a few psychoses that are related to different dementias. Visual hallucinations are more common with dementias than auditory hallucinations. I had a lady who used to see little people climbing in and out of her dresser drawer, and that was very disconcerting to her. She did not like those little people. Um, I've had clients who've seen snakes and ants crawling on their wall. Usually the hallucinations are not pleasant and they're very disturbing to the person who is experiencing them. As I talked about, delusions and paranoia are common with memory loss, and those are present in about 41% of people with Alzheimer's disease. So this is something that if you have older people in your life, and especially if you work with the older population, you will see this. So keep on the lookout for those. It's important that you know when your clients are experiencing this so that you can report this to their physician so that maybe they can have some sort of intervention and make their life a little bit easier and more comfortable and make them more functional. So um, there's obviously occupational performance deficits, especially if we're talking about psychosis related to dementia, because we already have the cognitive impairments, and cognitive decline is generally accelerated by the presence of psychosis. All right, personality disorders. I actually think this subject is kind of fun. I think it's fun to discuss. It's absolutely not fun if you have one of these people in your life because um, they can make you feel like you're going crazy. Um, about 10% of the adult population, including older adults, will have a personality disorder of some sort. So as I was reading through here, uh, I had a lot of questions, and I am very lucky in that I have a neurologist at my beck and call. My daughter is a neurologist, and as I learned from her through her residency and fellowship, Neurologists have a lot of training in psychiatry as well, because what part of you is involved in psychiatry? It's not kept in your big toe or your heart or your liver, right? It's kept in your brain. And obviously other parts of your body can impact mental health because you are at the mercy of your body chemistry. So if things start going wrong with other parts of your body, that can affect your brain. But that's why neurologists have a lot of training in psychiatry, because it's a brain thing. And as I was reading through here, a lot of the descriptions of the personality disorders seem to fit in, especially cluster B, with the psychoses. So my daughter had a really easy way of explaining it to me. And I'll highlight it when we get to cluster B. But she said, usually with people with personality disorders, we diagnose those compared to ones that are similar to psychosis, because people with personality disorders don't mind them, or they blame them on others. Whereas people who are experiencing OCD, for example, they are bothered by it. They would love for their life to be free of their rituals, but they just can't shake it loose. People um, with OCD personality disorders, they just do it and that's who they are. So let's talk about the three different clusters. So cluster A, and again, the weird, wild, and worried that you see under cluster A, B, and C here, again, that came from my daughter. She said that's how she remembers the three different clusters. So paranoid personality disorder and schizoid personality disorder and schizotypical typal personality disorder. It's like, okay, so we have schizoid and schizotypal. How does that differ from schizophrenia? And uh, Kristen's comment was, okay, let's think about Phoebe Buffet. You're all familiar with Friends. So Phoebe has lots of magical thinking, right? I remember one episode where a stray cat followed her home, and she was absolutely thrilled because it was sure that it was the reincarnation of her dead mother. So magical thinking, but Phoebe is able to function in the world and she's absolutely fine. She doesn't think there's anything wrong with her. And she's just happy in her little magical thought processes. That's the difference between somebody with a schizotypal personality disorder and schizophrenia. So let's go into cluster B, and this is the wild one. Um, the histrionic personality, the person who just gets all crazy and hyped up over nothing, somebody who's antisocial, somebody very narcissistic. Can't think of anybody in Friends that might qualify for that one. But then cluster C, that's the worried one. So what's the difference between an obsessive compulsive personality disorder and an OCD anxiety disorder? Well, let's think about Monica Geller. Again, let's go back to Friends. Monica definitely has an obsessive compulsive personality disorder. She is an absolute clean freak, and it gives her the creeps if somebody leaves I don't know, a dirty dish rag in the sink or whatever it is that's bothering her at the time. Um, but she's okay with that. And it's other people's problems because they're not clean. It's not hers. That's why that's a personality disorder and not an anxiety disorder. So what I want you to remember about that is the difference between what determines whether or not it's a personality disorder, is that people with them are okay with them. Right. Elder abuse is obviously not a diagnosis, but it is a nationally recognized problem that is way more pervasive than is reported. Um, about 10% of older people experience some form of elder abuse, and only 1 in 14 cases is reported. Um, if you look in the bottom right-hand corner of this slide, 0.05% of older people report financial abuse, and that is the highest type of abuse that is reported. So that's like almost nothing, right? These poor people are being physically abused. I don't think that I need to explain what that is. And believe it or not, there's quite a bit of sexual abuse. There's inappropriate touching. There's even unconsensual sexual intercourse that occurs in this population. There's certainly emotional and psychological abuse, just yelling and screaming, or expression of disgust, or I can't take care of you anymore. Maybe that's true. Maybe the person can't take care of them anymore, but there's a way to say that in a way that's abusive, and then there's a way to say it in a way that's kind. Financial abuse, we talked about that it is reported more frequently than anything else. Children, caregivers, other people coming in and either stealing or making the person feel guilty if they don't give them any of their money. Most frequently, these people are on fixed incomes and can't afford to pay for somebody else's fill in the blank, whatever it is that they're trying to take. And then there's neglect. There is neglect in the form of abandonment, meaning the older person who is unable to properly care for themselves is left to care for themselves without assistance. And then there's self-neglect, and that's frequently, if you think about what that might look like, frequently related to depression or cognitive impairments. So the person isn't bathing, isn't taking their medicine properly, isn't getting out, isn't paying bills, just whatever it is that they need to do to take care of themselves, isn't eating nutritional meals. So that's very, very common. There is adult protective services that has been established. And what do you do if you have somebody that you suspect is being abused? In my practice, I have worked with older people, most frequently in skilled nursing, in which case the person that this is reported to would be the social worker at the skilled nursing facility. There is also social worker and nurse case manager in home health. There is somebody who's in charge of abuse in acute hospitals. So this isn't something you would never confront a person that you think is abusing an older adult. There are certain chains of command that you go through. If something's happening in your neighborhood and you're concerned, you can call Adult Protective Services. There is a division of Adult Protective Services in every state. Unfortunately, it may go under different names, and you might have to look a little bit, but every state is mandated to have it. In Florida, this falls under Department of Children and Family Services. So, what do we as occupational therapists do when we have a client with a mental health condition? Well, let's go back to the OTPF. Our job is to bring back health, well-being, and participation. So depending on what's happening, number one, let me back up. Number one, it is crucial in every single setting, in every single circumstance, to really get to know your client, to use your therapeutic self, to listen to what the person is really saying, to try and understand who they are, where they're coming from, and what their lived experience is, without overlaying any judgment or preconceived notions that you may have onto that person. When you really listen, that's when a lot of times you get to know where the real problems are, and you can't help with the problems until you know where they are, right? So sometimes it's just skills training. Sometimes people need to relearn or to compensate or to have adaptive equipment. Sometimes environmental adaptation helps. Fill in the blank for that. That's a whole nother group of lectures on environmental adaptation. What about education? Being able to understand their condition and understand where they're coming from. A lot of these conditions have medical intervention. There's medical intervention for depression, for bipolar, for psychoses. So certainly being a part of a team that's working together and educating the client on their diagnosis and what those factors are. Referring people to peer support groups. This especially works well in my experience, widow support groups. And when I say widow, it's men and women. Um, people become depressed when they lose a spouse. They don't want to go out. They don't want to be around a bunch of happy people, but being around a bunch of people who really understand what they're going through and have been through that is very, very helpful. Obviously, knowing the limitations of your skills and reporting symptoms when you see them and referring to the appropriate diagnoses. I know that in skilled nursing facilities, there's generally a geriatric psychiatry service. And my experience with those folks is they're really, really good. I had a great relationship with the nurse practitioner who used to come in from Geri Psych where I worked, and she would also always speak to me about, is the medication working? What's the person still doing? What are they not doing? How can she help? So that was a really, really great team. And another thing to remember is that you really need to break things down, especially when somebody is depressed or if somebody is manic even. Break things down into small, reasonable pieces. These are in the example of somebody who's depressed. These are people who just normal life is absolutely overwhelming. So going in and saying, okay, we're going to get up and get dressed and start your day. Well, getting out of bed is absolutely overwhelming, much less getting out of bed, walking to the toilet, going to the bathroom, washing up, brushing teeth, changing clothes. That's beyond their ability to process. So I don't know if that's too much. How about if we just brush your teeth and sitting on the edge of the bed here? That's going to really help you to feel good. I'll help you. So let's break it down into a little piece. Likewise, for somebody who's manic, who not only wants to get up and do all that stuff, but they want to go out then and paint the building or get their roommate dressed, and the rest of the people, they're going to organize the Alleluia chorus for Christmas next week. Let's break that down into a little piece. You know what? I think the Alleluia chorus is a little bit too much. How about if we just get dressed and then maybe I can bring some music in for you to listen to later. So tap into something they're interested in. I'll hook you up with the activities director and maybe they have a singing group. Break it down. Let's listen to the person, what's going on with them, and make it more realistic. All kinds of many different things. It really just depends on the client, what's going on with them, what do they need to do, what do they want to do, and what are they having trouble doing. So I hope you found this interesting. It is very, very important in working with the geriatric client. If you have any questions or comments, I'm always free for conversation. Email me, or we can even set up a time to chat. I hope that you guys have a great day. And this is Happy from your clients that now are free from their mental health conditions because you are such a good OT.